Well, good morning, everyone, and welcome to our grand rounds. I think from a housekeeping point of view, please fill in your evaluation forms, and we welcome also our viewers on the live stream channel. Today we have a very special grand rounds with a very special speaker who is actually a dear friend and an authority in the field. So it's great to welcome Dr. Chris KRAMER from the University of Virginia, where he is the Ruth Heed Professor of Cardiology as well as Radiology at the University of Virginia. He's been in the University of Virginia since 1999, and before that did his training at the University of Pennsylvania. He's really an authority in cardiovascular MRI and has touched many fields in cardiovascular MRI, including ventricular function, ventricular remodeling, myocardial viability, Hypertrophic Cardiomyopathy, where he's a co-PI of the large international registry of hypertrophic cardiomyopathy. He's also an expert in cardiac MRI in vascular disease and peripheral vascular disease. And he told me that he was here about 10 years ago talking about peripheral vascular disease. Certainly internationally renowned for so many things. He's currently on the board of trustees of the American College of Cardiology, was previously president of the Society for Cardiovascular Magnetic Resonance. He's executive editor for JACC Imaging, as well as associate editor for JACC, published extensively in the field, and I think SCMR recognized him with a gold medal in 2015. So it's really a pleasure to have you, Chris, as a speaker and as a friend. I think we go a long ways and we share so many things. So it's great to have you, and please help me welcome Dr. KRAMER.
Bill, thank you for that very kind introduction. It's indeed a pleasure to be here. And it was, about 10 years ago that I was in Houston talking about peripheral arterial disease. So it's good to be back and good to visit with old friends like Bill. Unfortunately, a snowstorm kept me away from dinner last night, but I made it in for this morning. These are my disclosures. I will be talking about the use of gadolinium, which is not yet anyway, specifically FDA approved for use in the heart. One of the companies is working, and hopefully soon that will be FDA approved for cardiac use. So today we're going to talk about hypertrophic cardiomyopathy. First, start by talking about the disease process in general, the genetics, the pathology, imaging, especially cardiac MR imaging of HCM, the natural history, and a bit about therapy. And then the latter part of the talk, I'll describe the Hypertrophic Cardiomyopathy Registry, which Bill described, which is NIH-funded U01, which your institution has been taking part. So this is a typical pathologic specimen from a patient with HCM who died suddenly. He or she had the classic form of HCM with asymmetric septal hypertrophy. The septum is quite thick, but as you see, the lateral free wall is very thick as well, and that's seen quite often. It's not always that the other non-hypertrophy walls are thin. You often see hypertrophy in other walls as well, despite the asymmetry. There are a number of terms that are thrown about in this disease, but really the correct term is HCM, or hypertrophic cardiomyopathy. If you call it HOCM, you're wrong about 2/3 of the time, because there are many patients who are not obstructive. So if you call it HOCM, and you're labeling them as obstructive, and they may not be. Older terms, IHSS and ASH, we really don't use anymore. Asymmetric, these are specific subtypes of HCM, so really the proper term is HCM, and that's the one we should all use. There are a number of variants, and we'll describe many of these during the course of the talk. I'm really talking about the genetic form of the disease today, not the acquired form, which is hypertensive hypertrophic cardiomyopathy, the elderly, usually elderly, mostly women with outflow obstruction due to change in geometry of their heart in the setting of chronic hypertension. We're really not going to be talking about that. The genetics are quite complex. Essentially, there are a number of contractile proteins in the heart, as you're aware. Essentially, a mutation in any single one of them can lead to the phenotype of hypertrophic cardiomyopathy. The most common that we hear about most often, the beta-myosin heavy chain, myosin-binding protein C, but any of the troponins mutations in those genes can lead to HCM as well. This is an older slide. At that point, there were 1,400 mutations described, probably several hundred more since this cartoon was published in Lancet in 2013. The underlying pathology is one of myofibrillar disarray, patchy interstitial fibrosis. The intramural coronary arteries are abnormal. They're surrounded by fibrotic material. And there are mitral valve structural abnormalities quite commonly as well. And pathologic studies show that the mitral valves are, that the endocardium is part of the hypertrophic disease. The mitral valve leaflets are elongated and the area are larger than in controls. The disease occurs in 1 in 500 individuals, although a recent study suggested that perhaps it may be more common, up to 1 to 2 to 300, as the genetics have advanced and advanced imaging identifies more patients, but I think most in the field still say about 1 in 500. It's typically familial, although it can be sporadic. The mutations tend to be autosomal dominant, and it's the most common genetic cardiac disease. Characterized by unexplained hypertrophy, so absence of some load on the ventricle that leads to hypertrophy, such as aortic stenosis, etc. And the onset is typically from adolescence. At the bottom here are images on the left of a patient with asymmetric septal hypertrophy, a 4-chamber long-axis cine MR image. On the right is a normal individual. And above are pathologic specimens from similar individuals. In the normal, you see the normal myocyte bundles lying in parallel, whereas in the patient with HCM, there's myocyte swirling and disarray and interstitial fibrosis. The disease, as you know, is associated with an increased risk of sudden cardiac death and heart failure. In fact, it's the #1 cause of sudden death in young patients, especially athletes. And every year we hear about 1 or 2 prominent athletes that die suddenly, often from HCM. The pathophysiology involves 4 interrelated processes in the setting of obstruction. There's often diastolic dysfunction with or without obstruction. Myocardial ischemia due to demand-supply issues because of the excess demand from the hypertrophy and also the fibrosis around the intramural coronary arteries, as well as mitral regurgitation is an important part of the pathophysiology in many of the patients. The physiologic consequence of obstruction include increased intraventricular pressures, prolongation of ventricular relaxation, increased myocardial wall stress, increased oxygen demand, as I mentioned, and a decrease in forward cardiac output from the obstruction itself. These are typical ECGs of patients with HCM. On the top left is a patient with massive LVH with significant repolarization abnormality. Another common finding of these pseudo-infarct patterns here. A patient without a prior infarct has Q waves inferolaterally. That's quite common in patients with HCM, the pseudo-infarction pattern on ECG. 2D echo is the classic modality used to screen in HCM and diagnose obstruction. This is a still frame from a patient with massive asymmetric septal hypertrophy in diastole and then in systole. You see the chordal systolic anterior motion when the chords abut the septum, leading to outflow obstruction. The continuous wave Doppler, this is the typical form of the wave with a late peaking so-called dagger shape of the obstructive flow out the LV outflow tract. It can be sometimes difficult to distinguish that from mitral regurgitation, but remember that the mitral regurgitation jet will be more rounded and generally holosystolic. In patients with obstruction in MR, this is the classic V sign that one can see in the setting of both systolic flow obstruction in the LV outflow tract, as well as this jet of mitral regurgitation that is at 90 degrees to the jet of outflow obstruction. So the classic V sign, systolic V sign of obstruction and MR that occurs simultaneously as the anterior leaflet of the mitral valve is pulled towards the septum. This is a patient of mine who has an interesting form of HCM with really mild asymmetric septal hypertrophy, but the chordal SAM occurs way down in the mid left ventricle. And you can see that the turbulence starts quite high in the cavity. And he ended up failing medical therapy, requiring myectomy and also mitral valve repair to lead to improvement in symptoms. But the myectomy the surgeon had to take muscle out down into the mid-ventricle because of the site of obstruction, as well as to shorten the cords to the anterior leaflet. Well, MR has evolved into a very important modality in this disease. For one, it tends to be more sensitive than echocardiography for picking up unusual forms of hypertrophy. Echo is a great screening tool and it works quite well, but there are subtypes of HCM, especially apical HCM, which can be difficult by echo because of you can think that it's just foreshortened as opposed to true apical HCM. And then basolateral hypertrophy can be sometimes difficult by echo. So studies have shown that MR picks up a couple % more cases of HCM than echo does. These are 6 different forms of morphologically that can be described by cardiac MR. Certainly many of these can be shown by echo as well. Here's a patient with classic reverse septal curvature with asymmetric septal hypertrophy. Here's a patient with very isolated basal septal hypertrophy, apical HCM, top right. Here's an unusual form of basal infraseptal hypertrophy, other locations of hypertrophy. And then this last form, mid-cavity obstruction with apical aneurysm, as it turns out, the paper in JACC from last year from the Marin group showing that this form is associated with worse outcome than some of the other classic forms in terms of ventricular arrhythmias and sudden death. This slide dates me a bit. This is a slide from studies I did as a fellow many years ago, published in Circulation, where we used a technique called myocardial tagging by MR to understand intramyocardial strain in this disease. So tagging involves radiofrequency and gradient pulses that null the signal in the myocardium at end diastole, these waffle grid type of black stripes. And these protons are nulled, and they remain nulled through the cardiac cycle. So one can actually track the deformation of the myocardium during contraction. What you see in this patient with apical HCM, that the boxes at end diastole deform and become trapezoids at end systole. That's normal. But you see that the boxes here within the hypertrophied apex, there's no shortening within the boxes. There's actually stretching. Even despite the ejection fraction at the apex being 100%, there's the cavities. There's no cavity at end systole, but each piece of muscle is doing less work, and the reason for that again is the myofibrillar disarray and the intramyocardial fibrosis. So, despite the excess muscle, there's marked dysfunction intramurally within the wall of the heart with HCM. This is shown as well in this short axis image in this patient with different patient now, asymmetric septal hypertrophy. You see at the end systolic image, there's normal deformation here in the anterolateral wall, but actually stretching of the tag stripes here in end systole. And we showed in a small group of HCM patients now 25 years ago that when you measure circumferential shortening on the y-axis as a marker of strain is reduced throughout the myocardium, but was preserved in the lateral wall. So let's talk for a few minutes about the natural history of HCM. It's remarkably consistent across studies. This is about 15 years ago, 225 patients with a relatively young cohort followed for 30 years. These numbers are remarkably consistent over time. Annual mortality is around 1%. cardiac mortality just under 1%, and the sudden cardiac death mortality at about 0.6%. In this study, if you had a high LVOT gradient, either at rest or stress, a third of those patients developed heart failure, and syncope was identified as a risk factor for sudden cardiac death. Primary and secondary care study from the Minneapolis Heart Institute, again, annual mortality 1.3%, very consistent, and predictors of poor outcome in this study were, again, elevated LVOT gradient and wall thickness more than 25 millimeters. Patients with obstruction have a worse outcome. This was shown in this New England Journal paper in over 1,100 patients, a quarter of whom had LV outflow tract gradient at rest more than 30 millimeters of mercury. They were followed for over 6 years, and in the analysis in terms of risk, the presence of obstruction was associated with a 60% increase in risk of death and a threefold increase in risk of heart failure or stroke. And remember that the gradient is dynamic, so it doesn't matter if the gradient is 32 or 62 or 82, because it might change an hour later after the patient drinks a glass of water or changes their preload or leans a little bit more on their left side when the echo is being done. What's important is that the gradient is over this threshold of 30 at rest or 50 with either Valsalva or exercise stress. So therapeutic trials that show a change in the gradient, you have to look at those with lots of grains of salt, because the gradient itself is so dependent on preload and afterload and the conditions of the patient in that particular moment in time. So really you should look at the gradient as more of a threshold, the importance of the gradient as a threshold effect, not so much as at the absolute number. But the gradient is important, or the presence of obstruction is important in terms of outcome. This was shown by Steve Ullman from Mayo Clinic a number of years ago. The red bar line is outcome in patients with obstruction versus those without. You can see in terms of the outcome much worse with obstruction. The graph on the right takes the same, I don't know, they mix up the colors a bit, but these again are the obstructed patients. Now the green line are patients who previously had obstruction who underwent myectomy. So the patients who underwent myectomy, you return their projected outcome to that of patients without obstruction and an underlying HCM. So myectomy and relieving the obstruction can return the prognosis to that without obstruction. Exercise performance is also important, as shown in focused on the right side of this slide. This is data from Melinda Desai, the Cleveland Clinic. If you have normal exercise capacity in HCM, your outcome is terrific. Anything less than normal predicts adverse events. So what do we have in terms of medical therapy? Well, today it's somewhat limited, but there's a lot of promise in the future for new agents that can treat this disease. Briefly mention one or two of them. But what do we have at our disposal right now? Certainly beta blockers are the mainstay of therapy for patients with obstruction and or diastolic dysfunction. They increase diastolic filling, improve relaxation, decrease myocardial oxygen consumption. But don't think you're preventing sudden cardiac death with beta blockers, because you're not. They don't change the incidence of sudden cardiac death. Calcium channel blockers are an alternative to beta blockers. Sometimes we use them in combination. Typically we're limited by bradycardia and using them in combination unless the patient has a pacemaker, but they too can augment diastolic filling and relaxation. For patients who have persistent symptoms despite beta blockade and or calcium channel blockade, disopyramide, the antiarrhythmic agent, is a second-line agent in those patients. Why is it used here? Well, it's not used anymore for patients with primary ventricular arrhythmias because it's powerfully negatively inotropic, and that's how it works in HCM in terms of reducing the outflow tract gradient. It's usually typically used in combination with beta blocker, and it can lead to symptom relief in a subset of patients that then don't require more invasive therapy. Mentioned myectomy. It's the leading procedure in terms of the next step for therapy in terms of patients who failed medical therapy and with persistent symptoms of outflow obstruction. As you're aware, the surgeon usually removes the basal septum, the area that's causing the obstruction, with or without concomitant therapy of the mitral valve leaflets, and have shown you how that returns the patient to unobstructive prognosis. Myectomy in U.S. guidelines is the #1 choice for therapy after failing medical therapy. In the European guidelines, it's different. The Europeans favor alcohol septal ablation, in which I think this procedure is done quite frequently here, as well as myectomy, where the catheters slipped into the first and or second septal perforator. A balloon is blown up, alcohol is injected, leading to a controlled myocardial infarction of the basal septum, which leads to then thinning and reduction in the outflow tract gradient. This is a therapeutic algorithm that I think is quite useful, published in Barry Marin's Lancet review a few years back. There are patients who are genotype positive, phenotype negative. They need no therapy. There is ongoing study led by Carolyn Ho of valsartan in these patients to see if one can reduce the progression to the phenotypic positivity. That study is ongoing and the results are not yet available. In patients without symptoms, really there's no therapy that's indicated because you're not going to change outcome. We'll talk about sudden cardiac death risk factors in a moment. Patients with AFib and stroke, they're treated like any other patient with AFib and stroke in terms of the standard cardiac therapies. If a patient has end-stage heart failure in the setting of HCM, which is, remember, HCM, generally the ejection fraction is normal to hypernormal. If the EF is less than 50% in the setting of HCM, that's considered end-stage, and they go into the category of sort of end-stage heart failure and are treated as such, sometimes with VADs or transplant. Those with heart failure symptoms from obstruction, we've talked about the drug therapy. If they're refractory, if there's no outflow obstruction, less than 30 at rest or after exercise, and the EF is preserved, really continued drugs. If they do have obstruction at rest or with exercise provocation and they fail drugs, then myectomy is often the first choice, with alcohol ablation as a second choice. Typically, at our institution, we reserve alcohol septal ablation for patients who have contraindications for or higher risk for surgical intervention, generally elderly, frail patients who might not do as well in the operative setting, and we really withhold alcohol ablation for those patients. So the issue in HCM and the genesis for our study that Stefan Neubauer and I are co-principal investigators of, HCMR, is that presently used clinical predictors of adverse outcome are weak, which limit clinical trials of novel therapies for either sudden death or heart failure. There was just a paper 2 weeks ago in Circulation in patients using there's an ESC risk score for sudden cardiac death. And even this risk score, which was just published in 2014, it used a lot of morphologic and historical factors, no imaging factors other than the outflow obstruction and left atrial size. But it did well at differentiating high-risk patients, but didn't add anything at all to differentiating low and intermediate risk patients. So there's still a lot of work to be done in terms of predicting risk in this disease, including predicting sudden cardiac death risk. So the U.S. guidelines use these top three, and these were published by Bernie Gersh in 2011, use these top three to predict sudden cardiac death. Family history, syncope, wall thickness greater than 30. Minor criteria are either non-sustained VT on a Holter monitor or a hypotensive response on exercise treadmill testing. But the problem with these is that they're really the tip of the iceberg. First of all, they predict sudden cardiac death. They don't predict heart failure. Secondly, the majority of events occur in those with either zero or only one of these risk factors. So you're missing the bulk of the iceberg. The other problem in this disease is that typically you're considering placement of ICDs in young patients, and they're going to have them for 30, 40, hopefully 30, 40, 50 years. So the complications become a bigger deal in these younger patients. And in this older paper from Barry Marin on primary prevention ICDs, appropriate therapy was only instituted about 17% over 5 years, and the rate of inappropriate shocks or complications were higher than the use of appropriate therapy. So that's food for thought, and points out to the need for really careful risk assessment in these patients and only putting in ICDs in those who are truly going to benefit. I'd like to turn now to the use of CMR in HCM. Talked about the ability to demonstrate the morphology. Here's a patient with both asymmetric septal hypertrophy as well as this interesting pattern of apical lateral hypertrophy. With MR, we can measure LV mass in a 3D way, LV volumes, measure the LVO outflow tract gradient, assess mitral regurgitation, quantitate MR, but all that can be done with echo as well. Certainly measuring LV mass is important. This study by Jacopo Lovato et al. Showed that the presence of markedly increased mass is associated with adverse outcome in the setting of HCM. But what MR offers that echo does not is the ability to image fibrosis, and this becomes incredibly important in this particular disease. So we use a technique called late gadolinium enhancement. I'm sure everyone in the audience is familiar with this technique, but just to remind you, we infuse standard clinical doses of gadolinium, image 10 to 20 minutes later, areas of scar fibrosis from whatever cause. There's a delayed washout as well as increased volume of distribution for the gadolinium in those areas. So when we image with a technique that nulls the signal from normal myocardium, areas of scar fibrosis appear bright white. And these are areas of generally replacement fibrosis. Differentiate that from interstitial fibrosis. So here are 6 different patterns in 6 different patients. Patient without any LGE, patient with confluent LGE here in the anterior wall, and focal, one might mistake this for an anterior wall MI, except there's subendocardial sparing here, and there's this subepicardial deposit here in the RV insertion site. Patient C, this is the classic form of fibrosis in the setting of HCM with RV insertion site, HCM, probably lower risk, but certainly when on pathologic studies, this is Bill Roberts' old pathologic studies, this is where fibrosis is seen most commonly. Another patient with RV insertion site. Patient F is a patient with massive septal hypertrophy, and you see this diffuse, fluffy pattern of LGE in this patient. Previous studies have suggested that LGE is present in between 50% and 2/3 of patients with HCM, so certainly we can't use its presence as a predictor of sudden cardiac death, because I just told you that the risk of sudden cardiac death is less than 1% per year. So you can't put ICDs in half or 2/3 of the patients with HCM, because you'll be putting them in many patients who don't need them. And again, as I mentioned, the risk of complications will be higher than the utility. Certainly the presence of LGE is a risk factor for a poor outcome. This is a meta-analysis published in JACC Imaging in 2016, showing that the presence of LGE is associated with a 1.8-fold increase in all-cause mortality, a 3-fold increase in cardiac death, a 3-fold increase in sudden cardiac death, and an over 2-fold increase in heart failure death. But it turns out that based on this paper by Chan and colleagues in Circulation in 2014, this is Marty Marin's group, that it's going beyond just the presence of late gadolinium enhancement. The extent of LGE is an important marker. What this study shows is that the stepwise increase in sudden cardiac death events as you go from no late gadolinium enhancement to less than 10% to 11 to 19% and more than 20%. And they suggested a cutoff of 15% or greater as increasing the risk of sudden cardiac death. In this study of over 1,100 patients from 4 centers, that patients were entered prospectively, but it really was a retrospective look based on the LGE. So next set of guidelines, this cutoff of 15% LGE certainly is likely to be included. But I mentioned that not all fibrosis in HCM is replacement fibrosis that we can image with late gadolinium enhancement. There's other type of fibrosis in all kinds of cardiomyopathies, but especially HCM, and that is interstitial fibrosis. And we now have a way of imaging that with cardiac MR, a technique called T1 mapping. Let's review how that works. So this is a cartoon from Eric Shelbert's review in JACC in 2014. This is a normal patient, blood pool, myocardium here. You see the normal patient has very little interstitial collagen, whereas a patient with a cardiomyopathy, or especially HCM, has more extensive interstitial fibrosis, this lacy blue material. If we give gadolinium and image 10 minutes later in a normal, there are a few molecules of gadolinium left in the interstitium, but if we image a patient with a cardiomyopathy, especially HCM, we see many more molecules of gadolinium caught up in the collagenous fibrotic tissue. So remember that gadolinium is a T1 shortening agent. So it displaces water and the T1 is shorter. We can measure the T1 of the myocardium using MR techniques. And in the setting of cardiomyopathies, because of the increased gadolinium in the interstitium, the T1 will be shorter. I'm not going to go into the physics of the technique of T1 mapping. If you're interested, our review in JACC Imaging in 2013 will go into it as to how we measure T1. But we can use these measurements to actually calculate the extracellular volume of the myocardium. So for the first time, we have an imaging tool that can measure not only the mass of the heart, but we can measure the mass of the interstitium and subtract that from the total mass, and we can measure the mass of the myocytes. So how do we measure, calculate extracellular volume? This formula looks more complex than it is. Essentially, we measure the T1 of the myocardium before and after contrast, the T1 of the blood before and after contrast, use a correction factor for the hematocrit, and with that, we can calculate the extracellular volume of the myocardium. This has been carefully validated against biopsy evidence of interstitial fibrosis in HCM and AS. This paper a few years ago in Circulation. Here's an HCM T1 map. What they did in this study was take patients with AS and HCM or going to surgery, myectomy or AVR, did a biopsy, and then correlated the volume of distribution of gadolinium, not ECV in this setting, because this is before the ECV calculation developed, but this is the volume of distribution of gadolinium correlating with the collagen volume fraction. So you can see it's a validated way of measuring interstitial fibrosis. We can also measure the T1 before contrast. As it turns out, in HCM, this is mildly elevated. This is data from the Oxford group with Stefan Neubauer's group showing that there's a slight increase in native T1 in patients in segments that don't go on to show late gadolinium enhancement, even higher in those segments that go on to show late gadolinium enhancement. Now, because of overlap, these numbers aren't necessarily useful in HCM. Where it is typically useful, native T1 is 200 milliseconds longer in patients with amyloidosis. So one can make the diagnosis of amyloidosis using cardiac MR without giving contrast, and that's important in many of these patients who have renal insufficiency. But ECV is clearly elevated in HCM. This is data from the Brigham group showing that, and this data is very tight, that normal extracellular volume, if we biopsied you or me, or imaged you or me, our ECV is 25%. Whereas in patients who are genotype positive, phenotype negative, their ECV is around 32, and around 35 in those patients who are phenotypically positive. So maybe a marker of the early forms of the disease, but certainly elevated increased interstitial fibrosis in patients with phenotypic disease. The genetics we've mentioned, but remains the question, do sarcomere mutations inherently cause increased susceptibility to injury and fibrosis? It has been shown in one preliminary study that myofilament positive HCM genetics are associated with adverse outcome, but these are smaller studies, and larger studies clearly need to be done. Certainly there are biomarkers of this disease. One important one may be the C-terminal propeptide of collagen, or PICP. Carolyn Ho from the Brigham has shown that there's stepwise increase in this biomarker in circulating blood from controls to those who are genotype positive, phenotype negative, to those with overt HCM as shown here on the right. In fact, in overt HCM, the levels of PICP were 60% higher. Troponin T is actually high sensitivity. Troponin T is a marker of adverse outcome, shown those in the highest quintile of troponin T have adverse outcome in this disease, as shown in this Japanese study. So this takes us to the setting for our U01 that was funded nearly 5 years ago now. It's U01, meaning it's a cooperative agreement with the NHLBI, so that we have members of the NHLBI staff on our executive committee. This is our website if you're interested in more information about the study. The goals of our study are to change the existing paradigm in HCM by markedly improving risk stratification, establishing risk predictors to select patients for future clinical trials, to prevent sudden cardiac death and heart failure, identify surrogate endpoints, and improve morbidity and mortality in a cost-effective manner. So we designed it as a definitive observational registry of 2,750 patients with an established diagnosis of HCM, not a screening study. With enrollment, we planned over 2 years. It took us 3, and then follow-up over 3 to 5 years with a mean of 4. The study design was to include patients with ages 18 to 65. We recruited 44 sites in North America and Europe, including yours, with dedicated HCM centers and CMR capabilities. And I mentioned the follow-up plan. Primary endpoints are cardiac death, any cardiac death, including sudden cardiac death and heart failure death, aborted sudden cardiac death. So patients with devices were excluded initially, but many patients got devices after entry into the study. Those who have appropriate ICD therapy in follow-up, those will be included as primary events. Need for heart transplantation. Secondary events include all-cause mortality, ventricular tachyarrhythmias, heart failure, hospitalization, AFib, and stroke. We're planning to use tree-based mining methods to identify the key variables that predict the primary outcome, the standard clinical variables, CMR variables, especially the LGE extent and global extracellular volume. We'll look at the genetics as well, and a whole slew of biomarkers will be examined as well, and these are the ones that we pick out that will likely be most predictive. How do we come up with this sample size of 2,750? We assume, based on the published primary event rates from many studies, that there be a 3-year event rate of about 4.2%. 2,500 patients gave us 90% power to detect a hazard ratio of 1.5 for at least one risk factor. We presumed a dropout rate of 2% per year, and that's where we got our final number of 2,750. Exclusions included prior MI or any evidence of obstructive coronary disease, prior invasive therapy for septal hypertrophy, known contraindications to contrast-enhanced CMR, either inability to receive gadolinium or implanted devices at the time. Not so much due to safety, because we know we can image those patients safely now, more due to what the devices would do to our imaging and our ability to image LGE and ECV. Incessant ventricular arrhythmias, end-stage diabetes, or pregnancy. Again, we plan 3 to 5 years follow-up, as I mentioned. I'll also point you to our paper in American Heart Journal in 2015 that described the study in more detail, if you're so interested. The CMR technique that we included, and it was about an hour-long protocol, standard cine imaging for LV mass, morphology, mitral regurgitation, LGE for fibrosis, replacement fibrosis, and T1 mapping for measurement of diffuse interstitial fibrosis. This is a schematic of the protocol. We started with native T1 maps, then did cine imaging, 3 time points of post-contrast T1 mapping, and in the end, late gadolinium enhancement to see replacement fibrosis. The genetics are run by the core lab at Oxford, led by Hugh Watkins. They're doing next-generation sequencing, and this analysis is ongoing. They're going to be analyzing complete coding sequence and flanking splice site sequences, and these are the sarcomeric HCM genes and clinically related disorder genes that they'll be looking for. Carolyn Ho at the Brigham is running our biomarker core lab. We're, again, measuring a host of biomarkers, including those of collagen synthesis, such as PICP that I mentioned earlier, as well as collagen degradation, bone metabolic activity, hemodynamic stress and myocardial injury, and serum markers of fibrosis. This is the diagram of the executive committee of HCMR, Stefan Neubauer and myself. Bill Weintraub, now at MedStar in Washington, is running the statistical core. Hugh Watkins and Carolyn Ho I mentioned, and a slew of cardiovascular MR investigators that are involved in core laboratory measurements. We had 44 sites in our study, 22 in Europe in 4 countries, 22 in North America, including 4 in Canada. You can see that there's the one soul heart in Texas, and it's a Methodist. Enrollment was, I'm happy to say, was completed almost a year ago now. We planned to enroll within 2 years, but it took us 3, and we actually got to an N of 2,774. So we overshot our 2,750. There was a flurry of recruitment in the last week or two. And Stefan Neubauer makes me show this slide. I try not to, but he says if I give a talk, I have to show this. That's the red. The red is Europe. It's the tortoise and the hare here. You know, we were way ahead in North America for the longest time, and then in the last couple of months they lapped us. And but there was 1% difference in recruitment between Europe and North America. So just some tidbits about, we've analyzed certainly the entry criteria. We've completed the imaging analysis, although the statistical analysis is ongoing. Obviously, we need to wait for enough events. We're only at a mean of about a 1.5 follow-up now, so not enough time has elapsed for us to be able to predict events yet. But the mean age of the patients were 49, 71% male. We did have 17% minority populations. About a third had a first-degree relative with a history of HCM. 13% had a history of syncope. 5% history of heart failure. 3% history of stroke. 9% history of VT. 11% history of AFib. Hypertension was quite prevalent. Diabetes was less so. Almost 50% had a history of any smoking previously. Maximum wall thickness by echo was 18 millimeters. And at entry, over half were on calcium channel blocker, about 19%, half on a beta blocker, 19% on a calcium channel blocker, and 24% on either an ACE or ARB. In terms of our baseline imaging findings, LVOT obstruction was present in 42%, so minority of patients, but nearly half. The rest gradient, those with obstruction, a mean was 24, with a stress gradient of 53. MR was present in 58% of patients, but in only 12% overall it was at least moderate to severe or severe. In terms of our CMR Cine analysis, mean LVEF was preserved, 64%. Here are the volumes. The mass was significantly elevated. And by MR, the mean maximal wall thickness was 21 millimeters. Left atrial size, 48 millimeters. In our study of over 2,600 patients completed the MR and had complete MR data for analysis. LGE was present 50% visually. So actually it turns out in this wide swath of HCM patients, only half have visual replacement fibrosis. When we use the quantitative 6 standard deviation of the noise in remote region, actually 58% had any LGE. The native T1, we're still analyzing this because we have to break this down by field strength, but it is elevated. And the extracellular volume in this large group was 0.30. Remember, normal was 0.25. So clearly there's extensive interstitial fibrosis in these patients. In terms of endpoints, this is the endpoint committee, 2 electrophysiologists led by John DeMarco from our institution, and 2 heart failure experts go through all the endpoint events to assess whether they should be counted as a primary or secondary endpoint. As I mentioned, we now have, on average, a 1.5 of follow-up, over 4,000 person years of follow-up. We've noted 18 cardiac deaths, 10 either aborted sudden cardiac death or appropriate ICD therapies, and 1 heart transplantation, leading to 29 events. So if you do the calculation at 1% per year, you'd expect about 40 events to this time point. But there's a lag between the events happening and our ability to count them. The events have to happen, the site has to contact the patient, and the event might have happened 8 months earlier. The paperwork then needs to be collected by the site, sent to our contract research organization, ICON, who then puts the paperwork together, sends it to the event committee. The event committee takes sometimes a month or 2 to get back. And so there's a 6-month lag between the event and us actually counting them. So we feel like we're on track in terms of the expected event rate. But we definitely need to get over 100, close to 125 events to really improve the power of our statistical models. And so for that, that's going to take another 3 or 4 years to get to that, have over 100 events to be able to count. In terms of secondary events, 1 non-cardiac death, cancer-related death, 17 heart failure hospitalizations. New onset AFib is highly prevalent in this patient group, and then 16 non-fatal strokes. We have this interesting, as we prepare to our renewal to try to get money to follow the patients longer, because the grant actually ends on April 30th, although we have money for a no-cost extension. We took a look at the first 14 patients with events and looked at those with events and matched them as closely as we could to 14 patients in the study that didn't have events with all the clinical characteristics, and looked at some of our biomarkers. And just in 14 patients, already the patients with events had a markedly increased BNP and a doubling of their high sensitivity troponin compared to the controls without events. So just with 14 events, we're already seeing powerful predictive value of biomarkers. So when we have 125 events and all these variables to measure, we expect that at the end of this study we'll have a smartphone app that you at the bedside can put in all the clinical and imaging variables, genetics, biomarkers, and come up with a 5-year risk of sudden cardiac death or heart failure for your patient, which will enable you to take care of your patient better. Potential limitations of our study: it's a composite endpoint, so whether we'll have predictive value to predict sudden cardiac death versus heart failure death, we're not sure. The event rate, as I mentioned, is relatively low. We excluded those with prior ICDs who are likely at higher risk, and we include those with prior septal therapies, but we know that the septal therapies return prognosis to those without obstruction. We used an age cutoff of 65 because we didn't want to have other causes of mortality, especially coronary disease, muddy the waters. So in summary, HCMR study has the potential to identify important new risk factors in HCM that will improve prognostication and identify targets for novel therapies. With that, I'll end, and thank you for your attention.
Thank you very much, Chris. Any questions?
Thank you very much indeed for an elegant lecture. So I have 2 questions. Patients who are referred for CMR because they have genotype positive, but phenotypically nothing on CMR does suggest HCM. They'll probably get annual echoes and physical exam, but would you recommend a CMR down the line? That's the first question. And then the second question is, what is the role of pharmacological stress testing in patients with HCM?
So the first question is, the role of CMR in patients with genotype positive, phenotype negative. I think at this point, echo remains the screen. If the patient has difficult windows or some other reason, MR, we certainly can use MR. One could measure ECV in those patients, but we don't yet know what to do with that information, and we don't have any specific therapy yet we wait the valsartan trial to understand whether there are particular therapies in those patients that can slow the progression to phenotypically positive HCM. So I think the verdict isn't out yet. I think echo, again, remains the screening test of first choice with the caveats that I mentioned. Your second question was the utility of pharmacologic stressing in these patients. Well, the utility of stress imaging in these patients in general is problematic because they all have 50% have fibrosis, and it's been over the years. You look back at thallium studies and other studies that suggest ischemia where there may just be imaging scar, and so one really needs to be able to differentiate scar from true ischemia. I think certainly MR has the ability to do that because we're imaging scar directly. I think exercise stress is more potent in this patient population in terms of assessing prognosis because you want to measure a gradient during exercise stress. Measuring, I don't know what a gradient during vasodilator stress means, and I don't think anyone does. So it depends on the question. If the question is does the patient develop obstruction with stress, then you really need to do exercise. If the patient the patient has chest pain and you're wondering about epicardial coronary stenosis leading to ischemia, then stress CMR seems to be an excellent choice because I think nuclear testing is problematic because of the difficulty in terms of imaging, differentiating scar and ischemia. I think stress echo is a problem in these patients. Often they have small cavities and finding wall motion abnormalities is probably problematic.
Are you doing stress to look at gradients, and what kind of stress modality are you doing? Meaning immediate post-treadmill or supine or upright, which is even more difficult?
Immediate post-treadmill, generally with echo. So, but then the stress echo is being done not so much to look for ischemia, but to look for the increasing gradient.
Dr. KRAMER, it's an excellent lecture. I just had one question, but an observation before I asked the question. I saw a patient when I was at Mayo where there was a lawyer who had recurrent ICD shocks, high VT burden, was on amiodarone and started having side effects from amiodarone. And we saw this patient, it was Dr. Gersh actually, I saw him with him in his clinic. This patient did not want to be on amiodarone anymore because he was having recurrent ICD shocks, high VT burden, but he was having all these toxic side effects from amiodarone. He was otherwise asymptomatic. It was just he had a lot of LGE on MRI. He was just having recurrent VT. He did have a septum that was measuring around 18, 20 millimeters, if I recall correctly, but he did not have provocable gradient. And so he made it's novel, I guess. We proceeded with septal myectomy. And a year out, he did not have any ICD shocks. He was off amiodarone, and his VT burden had decreased significantly. He had a few non-sustained VT episodes on device interrogation, but nothing otherwise. So we know that when you do septal myectomy, you restore the survival to, is that because of less heart failure? Is it because of reduction in sudden cardiac death? Or can you comment on that?
I don't think it's well understood. I think most of it is thought to be reduced heart failure, certainly. That's an interesting anecdotal case of you wonder if most of his LGE was in the septum. You'd have to look at his images to understand that. But I'm not aware of how effective myectomy is. It's not thought that you're really altering sudden death risk. It's really more progression to heart failure. Though certainly there, anecdotally, as you pointed out, and some of the reduction in improved outcome is likely reduced sudden death, but most of it is reduced heart failure.
Dr. Lowry.
Gerald Lowry, thank you for the excellent talk. I'm a surgeon here, so forgive me for... I just want to endorse the role of echocardiography in this disease, particularly in these gray area patients. I mean, it's great when you have the big lump and the symptomatic patient and so on, but we get these people with persistent symptoms and a little lump. And stress echo, looking for gradients, I think is a very valuable thing. And also the morphology, our experience has been that MRI and echo, and then particularly TEE in the operating room, all give slightly different views of the morphology we're dealing with. And then the final thing, obviously, that you don't get to do is arrest the heart and palpate the hypertroph.
Yeah, I've never done that.
And I wouldn't recommend it. It may be that in the arrested heart, these more fibrotic lumps are easy to feel with the normal hypertrophied myocardium arrested. But I would say as a general comment that the imaging modalities tend to underestimate the magnitude of the hypertroph. That's not to say they're grossly underestimating, but we have these people with, it looks like a big thick septum, and it's not obviously a lump, but when you palpate it, it is a lump. The other thing from the point of surgery is just a couple of quick things. The extent of the surgery, as you know, has progressed tremendously from the old Morrow channel, which was supposed to relieve the suction, which was a 1 centimeter little cut down the middle of the hypertroph, to an extensive resection basically from each edge of the anterior leaflet all the way across. And it's been written in the literature the importance of the lateral portion of this resection. People tend to concentrate on the medial side, but the lateral side is very important. And particularly when we come to the issue of concurrent mitral regurgitation and the hypertroph, if you do a complete resection of the hypertroph, which we routinely do down below the level of the tips of the papillary muscles, and the anterolateral papillary muscle is commonly tethered or has incompletely developed away from the wall of the left ventricle, that needs to be thoroughly hollowed out on the ventricular side and mobilized down. And in our experience, which echoes a much bigger experience of Hartzell-Schaff, we almost never have to do a primary mitral valve procedure to resolve the MR in these people if you do that extensive, comprehensive surgery. The apical pattern is not common, but it's very easy to fix. The cardiologists who look at it think it's inoperable or they're not aware that surgery is available. The most common indication we've operated for is persistent chest pain. It's actually well diagnosed on a simple ventriculogram in the right view. You see the slit light, obstruction, mid-obstruction or distal obstruction, and then you mentioned with the aneurysm.
So you're doing myectomy for those apical HCMs?
Yes, through a little apical incision.
To the apex.
Yeah.
And interestingly, I saw some data recently which confirms what we find intraoperatively, that often the maximum fibrosis is in the anterior wall near the septum, not in the septum itself. In the big patch right in the middle of the anterior wall is commonly, whereas we're resecting down, we hit the really bad fibrosis.
Yeah,
really,
we'll have regional assessment. I didn't present it today. We have the data. I just didn't have time to show it. But we can actually, localize the most extensive areas of fibrosis. Certainly.
Your study is going to answer a tremendous number of really important clinical questions as we're presented with these people in the office asking us what to do. We try to use the guidelines we have, but as you pointed out, they're very incomplete. Thank you very much. It's really a great lecture.
Thank you for those very important points.
Well, we hope to hear more about it in about 2 to 3 years. I think when you analyze the data, I think it's going to be an instrumental study. John?
Hey, John.
Chris, hi. You've shown nicely in the periphery using CMR techniques. You've looked at oxygen uptake as a reflection of mitochondrial function. Are those techniques using CMR applicable in the heart?
Yeah, so one can do 31 phosphorus spectroscopy in the heart. It's quite cumbersome. It can only really be done in the septum, which actually in HCM may be that's a good thing. But there are 3 or 4 centers. You have to average the data over minutes. And so there are only 3 or 4 centers in the world that do cardiac spectroscopy well. We haven't even tried to do it because it's a long walk for a short slide. It's much easier in the periphery, in the skeletal muscle that's not moving than the moving cardiac muscle. So we have not tackled it. It's certainly available. One can do it, but it's not for the faint of heart.
Well, with that, we thank Dr. KRAMER for an amazing grand rounds, and thank you for coming with us.
Thank you for having me.